So many of these controversies, Benji's already done a really nice job covering. I might pause and highlight a few things. I might clarify a few things, but for the most part, we'll go fairly quickly. The first thing I'll do is say, don't think about 20 millimeters, think about 15 millimeters. You might have noticed that controversy, 10 to 20 millimeters, what do you do? The gray zone, well, you can do shockwave, uteroscopy, PCNL. Get rid of that gray zone and cut your size down to 15. Because PCNL's gotten better. Limitations of uteroscopy and shockwave have become more apparent. So we can do PCNLs now for stones 15 millimeters or greater. And as Benji said, in certain select cases, we might do it for a smaller stone. So essentially, PCNL, treatment of choice for bigger than 15, shockwave, treatment of choice for stones smaller than 15, and uteroscopy plays some role for larger stones and smaller stones that we'll talk about tomorrow. But when we talk about those smaller stones, when would you drop your criteria below 15? Essentially, it falls into the category where if you do shockwave, the fragments are going to have trouble getting out for whatever reason you see on this slide. Or if you try ureteroscopy, your ureteroscope is going to have a tough time getting to the stone. So anything anatomical or anything in terms of the anomaly of the kidneys, any strictures, any issues with bladder outlet obstruction, those would be reasons why, okay, maybe we should do a PCNL, even though the stone is smaller than 15. Now, we know that PCNL has the highest stone-free rate. What you might not know is that if you look at shockwave, ureteroscopy, and PCNL, and you look at what the quality of life is for the patient within the first 3 months after surgery, the one that's best is this dark gray. So the larger the circle, the better quality of life. PCNL has the best quality of life compared to ureteroscopy and shockwave. You might say, that's crazy. How could that be? It might be because with PCNL, we overstate the risk. We overstate the pain. We overstate the things so that the expectations are here. And then afterwards, they're like, oh, that wasn't that bad. Whereas with shockwave and ureteroscopy, we oversell how minimally invasive it is, how easy it's going to be. Oh, it's going to be a chip shot. You'll be back to work next week. Expectations are here, and then they have their stent pain, they have their Steinstrass, and they say, you know, I really don't want to do that again. So why don't we do PCNL in everyone? Quality of life is better, stone-free rate is better. 4 out of 1,000 people will die from PCNL. We'll be looking for Will's slides to say, oh, fuck, what do I do now? Deposition coming. So what can we do to try to decrease the risk of sepsis? Benji did a nice job covering some of the risk factors. I'll point out a few maybe that weren't mentioned. Bladder outlet obstruction, presence of a nephrostomy tube or a stent. Those are a few things that will also put you at a high risk for potentially developing sepsis. He already covered nicely what SIRS is, the limitations of using it. The advantage of using it in a clinical setting is because 37%, it's easier to look at how you can move that needle when you have a larger prevalence of an issue compared to the large study you would need to show a decrease in the risk of sepsis and death. He presented some meta-analyses, and this is just to show you too the slide. So first I was going to tell you, in terms of struvite, we all learned about purple. Purple was Proteus, Pseudomonas, Klebsiella, staph, urease-producing organisms associated with struvite stones. But if you culture the stones now, the struvite stones, E. coli and Enterococcus are the most common bacteria to find in stones. So the microbiology has changed. In the fine print, you'll see that at some point in the year preceding surgery, they did have a urease-producing organism. But because we treated that, got rid of it, something else ended up in the stone. What this tells us is it's going to be difficult to predict what's your best perioperative antibiotic, because it's not those urease-producing organisms that were sensitive to ampicillin, it's something else. Because of the risk of sepsis, because of the change in bacteriology, it makes it more challenging to follow the guidelines. So we've already had quite a few people who've told us, Arnold, close your ears, Jay, close your ears, EAU, AUA, both doing great work, but guidelines suck. They really try to sugarcoat things, try not to be too controversial, try to please everybody, really make it hard to come up with a solid thing that you can hang your hat on, rather give you a lot of weak pegs that the lawyers can hang their hats on. But essentially what this is showing is that only about 10 to 12% of people will actually follow the guidelines when it comes to using antibiotics for uteroscopy or PCNL because they're worried about sepsis and death. So one of the studies from Scotland, the first one from Tolly Cipro for 7 days, demonstrated that you could decrease the risk of SIRS significantly. The one from India using macrodantin, which is why we use macrodantin in the EDGE study, showed that you could sterilize the pelvic culture, decrease the stone culture being positive, decrease the risk of SIRS, and decrease the risk of serum endotoxin circulating. Benji already covered the EDGE studies, so essentially we'll say individualize the approach, identify the high-risk patient, those with recurrent UTIs, indwelling catheters, neurogenic bladders, struvite, stones, or pyuria. Struvite, again, you're looking for pHs over 6.5 or 7. You're looking for urease-producing organisms that would raise the consideration for struvite, but don't forget E. coli and Enterococcus are now the most common bacteria that you'll find, not the urease-producing organisms. So prone split leg position, very similar to Benji. I'll say you don't necessarily need to have two surgeons. You can have one surgeon who does the access ureteroscopy, gets the ureteroscope onto the tip of the papilla, and then passes it to someone they trust. Doesn't have to be another surgeon. Just someone who can hold the ureteroscope steady for about 2 or 3 minutes, while you then move to the flank and get your own access. You also don't need 2 endo towers. You don't need 2 of everything that's going to bump up the cost, make it difficult to work in the small rooms that we work in. Everything can be done with a C-arm monitor here, C-arm there, and the cysto tower here on a swivel monitor so you can move it back and forth between the 2 operating fields. So just a few things to re-emphasize. 2 centimeter stone. Don't usually use the sagittals to plan PCNL, but this does demonstrate another point as to why the upper calyx is ideal. Because of the axis of the kidney, the way it lies, it's most posterior. The more posterior it is, the shorter the distance you have to go to get into the kidney, the less likely your needle is going to end up somewhere where you don't want it to end up. And then as Benji showed nicely with his little weather map lines going this way and that way, very nice, Benji, the upper pole is going to let you get to more places with a rigid nephroscope. The goal of where you get your access is get as much stone out as you can with a rigid nephroscope, because then you can use an ultrasonic, not only fragment the stone, but suction it. As opposed to having to go with a flexible scope and a laser, and then you have to go in with a basket and fish all the pieces out. So this patient here, first step is you put up a wire using a rigid cystoscope in a woman or a flexible cystoscope in a man. One of the key things is to let all the air out of the tubing before you put your scope in, because if there's air in the tubing, it rises to the trigone, and it'll make it more challenging for you to identify the UO. Once the wire is up, we rotate the spine so the spine is on top. And just like Benji showed, except he had a nephroscope there, so anytime you have radio-opaque instruments or contrast, you're going to ramp up your fluoroscopy, increase the radiation to everyone in the room, including your patients. So try to avoid having radio-opaque things in your field. But with that little sidebar, spine is on top because that way when you move your needle to the right or left, it's moving intuitively. If you find that you're doing a lot of this motion, it means that you don't have the C-arm oriented properly, and it'll make it a little bit harder for you to align your needle with this, which is the tip of your ureteroscope. Where's the tip of the ureteroscope? It's looking right at the tip of the papilla. He emphasized why it's important to be on the tip of the papilla to minimize your risk of bleeding. And here you don't have to say 3 degrees for upper, 10 degrees for lower. You can do it based on how the scope looks. So if the scope looks straight like this, when you put your needle in, you're going to be right on the tip. If the scope is curved, then you rotate the C-arm towards the tip until it looks like that. And then you know that it's going to be in that avascular plane right at the tip of the papilla. So here you're able to use the scope and the curve of the scope to make sure that you're avoiding the blood vessels. So once we've laid the flat over the tip of the scope on the horizontal field, we then rotate it upwards to make the bullseye. The bullseye just means that you have the tip of the needle and the hub of the needle overlapping each other. And then here endoscopically, just to mention, the bubble here tells you that you have a posterior calyx. So you don't have to worry about, is it medial, is it lateral, is it a posterior or anterior calyx? You know because air rises. This just shows that the device that you might have been appreciating on the fluoroscopic image is made by Cook. So rather than use a Kelly or a hemostat, which again is radio-opaque and is going to increase the radiation to everyone in the room, it's also going to have a higher chance that you might inadvertently get your hands in the field of view. If you use this bar, it'll help you avoid radiation exposure and radiation injury. So once one has advanced the needle about 1 centimeter, we then rotate the C-arm away from us. And the reason you rotate the C-arm away from us is to judge the depth of the needle as it's advancing. Once the needle enters comes close to the tip of the scope, you ask your assistant to pull back a little bit to get perspective, because the tissue will move as the needle approaches, and eventually you'll see it pop through. So at this point, really, you're done. And I would say getting access is like dissecting the hilum. So if you find it enjoyable to come in and just staple the hilum after someone else has dissected it, then yeah, have your radiologist get your access for you. But if you really enjoy the challenge of the procedure, the real challenge of PCNL is getting the best access to be able to access the stone. So we've passed a Benson wire then, a Benson wire floppy tip, 15 centimeters. I have a Volts 1 ureter when I try to pull this wire through and through because I used a stiff wire. So it's important to have a 15 centimeter floppy tip. As you grasp it with a basket and pull it through, you want to avoid injury to the UPJ. Once you have one wire through and through, hemostat on both ends, you're safe. You don't need 2 wires. 1 wire is going to serve as your working wire and your safety wire. We do transition the wire using a 5 French open-ended to a super stiff from the Benson wire because it'll be easier to dilate. At this point, you can decide how you'd like to dilate. You can use Alken metal dilators, you can use Amplast disposable dilators, you can use a balloon. But the key is to watch as you dilate so that you don't overdilate and cause a perforation, or you don't underdilate, and when you look into the scope, you don't see collecting system, you don't see stone, and it's really difficult to get to where you want to go. And so this just shows you balloon coming in, sheath coming in, and we're set. So this will be just a short video to show you the process. Needle gets laid over the tip. One thing I'll mention also is before doing this, you look at the ribs to make sure that when you advance the needle, you're not going to be advancing on the ribs. If I had found that the rib was overlying the tip of the scope, I would have rotated the C-arm a little bit towards the head, and that would have thrown the tip of the scope above the rib, and then we would have gone in at a bit of an angle so that we could get into the appropriate calyx without hitting the bone. And so that just shows you how quick access is. We'll play it one more time, and this time I'll add a little bit of commentary. Needle horizontal. Use your finger to advance it a little bit through the skin. Once we've advanced about 1 centimeter, we rotate the C-arm about 10 degrees away from us so that we can judge the depth. As it approaches, the assistant pulls back a little so that they can get perspective, and then we look for the needle to come in, pass a wire, grab it with a tipless basket, and have through and through access. So as Benji mentioned, decreased fluoro time, decreased bleeding, decreased secondary procedures. This, I think, really highlights the point he made about how the lower pole is less forgiving. There are less blood vessels, less complexity of vascularity around the lower pole compared to this nice bare area here on the superior calyx. So we'll skip maybe the supine things. One of the things was, so basically I think it comes as a package. So we've got a few controversies: supine versus prone, mini versus maxi, ultrasound versus endoscopic. I think if you're going to do all 3 things, if you're going to do a mini perc, if you're going to do ultrasound guided, and then it makes sense to do supine. The reasons for that is that, number 1, I think the risk of injuring bowel is going to be higher when you're going lower pole supine. Number 2, if you're doing a mini PCNL, then you're relying on some of those fragments to efflux out of the sheath. And if you're doing a supine PCNL, your sheath will either be horizontal or tilted downwards a little bit. So you'll be able to rely a little bit more on gravity to help the fragments come out. So either you're all in or you're all out. You do mini perc, supine, ultrasound guided, or you stick with what's proven to be useful in your practice for the last 30 years. So I'm wondering which of these pressure points are going to be hurting me on Sunday after trying to ski again, but You look at this and you say, you know, prone it's a lot easier. It actually takes less time to position